Good afternoon, everybody, and thank you for having me with you today. My goal today is for us to talk a little bit about trauma-informed care and primary care. But it's really important for us to recognize that we're not all in the same place and not all of our facilities are in the full range if you look at it as a continuum of trauma-informed. So my goal today is to go through and take a look at, excuse me, at reviewing what toxic stress is, which a lot of you may already know, but just that we're all on the same page. And then recognizing some of the long-term effects of this on health, and then going on from there and really focusing more on some of the trauma-informed approaches that are guided by what we call the 4 Rs, or the realize, recognize, respond, and resist retraumatization. We're going to talk a little bit about trauma-informed centers and what you can do as an individual, again, because not all of us are in the same place, and sometimes some of us would feel like we would like our centers to be a little bit more trauma-informed than they are, but what can we as individual providers do wherever it is on the continuum? So I'd like to start with a case. I'm going to read a case to you, and we're going to come back to Jenny. This is Jenny, who's an 8-year-old, and she was brought to the clinic for her well child visit. And when she made the appointment, the mother denied any concerns other than Jenny was due for her yearly check. The screening for toxic stress, which we do, showed that there was a pediatric symptom checklist, which was within normal limits, meaning not any significant behavioral or emotional difficulties, except that there were several items there that endorsed sometimes. And these items were that she was complaining about aches and pains, absent from school, and worried a lot. And then when we looked to see adverse childhood events, it showed an endorsement of separation from a parent. Mother's PHQ-9, which we usually do because mother's depression may impact a child, falls in the mildly depressed range. And so the profile for us triggered some further questioning of the family. And upon further questioning, what we find is that Jenny has missed school 3 days since the start of the school year. She has reported that on those occasions, her stomach hurts. Mom denies any other symptoms, including fever, but reports that overall she's noticed that her appetite is down and her activity level is lower than usual. She has not been outside to play as much and has been lying on the couch watching television more. The only other information that we have that Jenny shares is that the last time she was in school, her stomach hurt and she vomited after lunch because she did not like the food. The kids laughed at her, and that made her feel sad and mad. And so let's keep Jenny in mind as we go through our slides today and see how we go back with her, what some things that we can do in the primary care setting. So going back to review adverse childhood experiences, and if there's anything that any of you get from my presentation today, will be that we never ask just about ACEs or adverse childhood experiences, that these are contextual. Things happen, but there are other factors that we have to take into consideration, like are they impacting functioning, and what is the impact on the family? What are the resilient factors a child might have? But giving that caveat that I'll probably go back to, when we looked and the research looked early on about adverse childhood events, what they saw were that there were certain categories: abuse, neglect, household dysfunction like mental illness in the family or separation, incarceration of a loved one, substance abuse, that really were impacting or somehow were correlated to adult health. In the original studies, we had adults reporting back before you were 18, did any of these things happen to you? And so what they found was that indeed there seemed to be a correlation between what happened to a child prior to age 18 and their adult health status. But this was a retrospective study, and so it filtered through adults, which were in the mean age of 40s, and remembering what had happened. Since then, a whole lot more research has happened. And since then, we know that we have to take into consideration not just the individual and the family, but the community in which they exist. And of course, for the populations that we work with, becomes very important. So while abuse and neglect and household dysfunction is important, what that is happening within the context of other things that cause chronic stressor in a child's life. And that could be things like family separation, it can be a transient lifestyle, discrimination and poverty, deportation fears, inadequate food, inadequate housing. So, all those sorts of things have to be taken into consideration as an adverse childhood experience and not just those initial 10, although very important. We have to take it in today. What we've seen and what the research shows continues to impact children, which is the community context of where they live. So, as a reminder, what is toxic stress? So, it's the extreme, frequent, or extended activation of the stress response that causes distress for the child, and it's going to lead a negative psychological and physical health outcome. So, we look to see that over a period of time, a child that has been exposed to prolonged sources of stress without protective factors to help them, that there's something that's actually happening physiologically in the brain. There are some neurodevelopmental impacts that we see. And it has to do with different regions of the brain that have to do with things like emotional regulation and memories and executive functioning. And the research has come out so strongly in terms of this correlation between adverse childhood events over a long period of time without protective factors, which we call toxic stress, and children's health, that the American Academy of Pediatrics has strongly recommended that during well child visits, we really take some sort of action in terms of assessing for the presence of trauma in children or toxic stress. Now, of course, the American Academy and their wisdom doesn't tell us how to do that, right? And so for those of you that are frontline workers, you know that easier said than done in terms of the time commitment that physicians have to get everything done. So we, anyway, have developed a way of doing that in our own clinics. And this is where we found Jenny to have had some positive things that we needed to follow up on. So we know that about a half to two-thirds of all US children have been exposed to at least one adverse event prior to age 18. Now, children of migrant farm workers are going to have higher exposure. A lot of times, the methods that are used to measure how much trauma there has been, including that initial childhood ACEs inventory, did not take into account things like a transient lifestyle or fear of deportation or some of the other traumas that our children have been exposed to. And so they tend to underestimate due to not having the tools that are appropriate for the population. By the way, this also happens with inner city youth, and the exposures, for example, to violence on a regular basis was never really accounted for in that first inventory of adverse events. So really underestimated what the children have been exposed to. We know that when we look at our own population here in Immokalee, which is an agricultural community with a very high number of agricultural farm workers and migrant farm workers, we know that our children have been exposed to a lot of events. By the age of 10 or 11, a lot of them already have 3 events that they have been exposed to on a chronic basis. So, this growing evidence is that this early adversity is, as I said, biologically embedded in the brain. And this chronic activation is going to lead to a stress response. And as we know, that stress response was that fight or flight syndrome, right? We either get ready to battle the lion or we relax. We're not meant to be in this highly activated state over a large period of time. But what if you are, what it does is that then you have difficulties with self-regulation, executive functioning, or the ability to plan ahead step by step what's going to happen. Academic achievement, therefore, gets impacted as memory and attention get impacted. And mental and physical health problems do persist into adulthood when you have these. The CDC continues to do surveillance, and continues, even though these early studies of adversity happened back in the 70s. They are important enough to continue to do surveillance. And so we know that as a result of that, the impact can be long lasting. Traumatic brain injury and fractures, depression, suicide, PTSD, unintended chronic health conditions, complications of pregnancy, educational problems. So we've got a vast number of research now that says that, this needs to be taken seriously. It really impacts all areas of functioning and health. If we take a look more holistically, as the researchers are tending to do now at those adverse childhood experiences, not just being an individual thing, if we conceptualize it like a tree with, you have these adversities of a divorce, mental illness, incarceration, maternal depression, all sorts of things that are happening. But if you look at the roots, what are the communities in which this is happening? It's not just in the individual homes, but it's poverty, discrimination, disruptions of lifestyles, lack of opportunity, violence. So the environment in which a child is growing up, is going to school, is dealing with daily life becomes just as important as what's happening in the individual homes and the individual experiences of a child. We cannot ignore it. So when we talk about a trauma-informed approach, it's getting into our heads that this is the life of the child. Some people experience trauma and they go on and they live regular lives without a lot of adversity, but others will have more difficulty when they experience traumatic stress, and they will have reactions that will impact them for a long period of time. We know that this is a public health component, this constant stress. It is a public health concern. I mean, violence has been called by the CDC violence as a public health indicator, right? And so poverty, food deserts, all of these things impact the child, not just the abuse that might be happening in the individual home or not happening. So the whole goal is to recognize that children, that patients may have been through adverse events, they may have been through traumatic stress in their life. And the last thing that we want is to re-traumatize our patients. So the goal is to always recognize that the person may not talk about it, but if we treat everyone as if we are likely to not cross that boundary of re-traumatizing. This is what trauma-informed care is. So when we talk about traumatic events, one way to think about it is the 3 E's. So it can be an event per se, and it can be an actual event or an extreme threat of event. In other words, you can be physically abused, or you can have the threat of abuse or the threat of harm to yourself that has been constant, or a neglect from a parent. And it can be something that occurs one time, or it can be over a period of time that this is happening. And then you have the individual's experience of that event. And they help to determine whether that's traumatic or not. It's their experience of it. And so, for example, a child that has been abused and the Department of Children and Families removes that child and puts them into a safer place where they're not being constantly physically or sexually abused, the child may experience that as a relief to have that parental separation. On the other hand, a child who might be traveling with their parents, trying to cross the border from Latin America to the United States, and they experience a separation that was not a wanted separation from their parents, that event may be seen as a lot more traumatic. So it's the experience of the event that we have to take into consideration as we talk to our patients. And then the effects. The effects could be immediate or they can be delayed. So what we know is that folks that go through these traumatic events, that they experience them as negative, they have problems coping with the normal stressors of life. They have problems trusting and benefiting from relationships. And we know that the ability to make social relationships is probably one of the top mental health predictors. So children have to be able to learn how to make social relationships. Managing their cognitive processes, like I said before, their attention, their memory, their thinking, which then may impact school functioning. Their ability to regulate their behavior and their emotions and to control how they express those emotions. All of that is impacted by events that can be negative over one time or over a period of time, how the person experiences it, and then the effects that they have. So, as clinicians and in clinics, what we're looking for is trying to think about a trauma informed care in the what we call the 4 R's, right? So we have to first realize that it's happening, not be oblivious, but rather to think about the fact that indeed there is widespread trauma in our society, and that there are different potentials for recovery from that, but just realizing that it happens. Recognizing then what the signs of that trauma is, looking for them, recognizing them in the individual and the families, and in our communities and the staff in our clinic. A lot of the work that we do with migrant farm workers happens in rural communities. The workers that are in our clinics oftentimes come from backgrounds where they may have been traumatized themselves. And so when we talk about a trauma-informed care, it's not just about the patients, but also the staff in our centers. And then we respond, integrating trauma procedures, policies that may be in the center as to how we approach patients, and then resisting the re-traumatization in what we do. So, for example, a child that may have been physically abused that gets out of control, probably putting them in a restraint procedure is not a good idea, because it's just going to re-traumatize them. A woman who comes in that has been raped, how we do a pelvic exam is going to be very different in terms of how we approach, so that we don't re-traumatize that person of an experience that may be a trigger for them, and become quite upsetting. So when we realize that all people and all of us have been in terms of some sort of event in our life, some more than others, realizing that it affects individuals, it affects communities. We've had a year of stressors in the country. We know that when there is violence by the police or any other entity that impacts the community, you have a trauma of the community, not just of an individual or a family. And so people's experience and behavior need to be understood in the context of their trying to survive adversity, right? They might be overwhelming circumstances, either in the past or now, and they're trying to do the best they can with what they have at the time, with when we end up seeing them. And so realizing that trauma has an impact on both mental health and substance use disorders, or just substance use in general, and that we really should be prepared to systematically address, through prevention and through treatment, all of our patients, not just a subgroup of patients, but all of our patients, because we don't know who among them may have been exposed. So recognizing, how do we recognize trauma in our patients? Individuals that are seeking services, but also the individuals that are providing services. Sometimes those of us that are providers, you may come in contact with someone that comes in with a presenting problem or a story that really might trigger a memory of something that you have been through, or maybe a previous patient that you were close to has been through. And so it's not just about the patient, but also the provider that is trying to serve. Recognizing that trauma screening and assessment is important, that we really need to take the time and devise some ways in each of our clinics to screen for possible trauma and then to assess whether there's something that we can do or we need to refer out of this patient. And we need to do this in the context of workforce development so that it's not just our nurses and physicians and psychologists that are talking about this, but also the frontline staff that are checking the patients in. You know, people that have been discriminated against or maybe have come to this country, maybe as illegal uh, workers or have come in not in the best through the best routes. When they approach a clinic and the front staff is rude or not welcoming, that can re-traumatize. We want our clinics to be someplace that people feel safe, whatever their background is. And so frontline staff needs workforce development also. And so ideally, in terms of how we respond, all of our policies and our personnel have been exposed to the idea of trauma and of stress and of responding in a trauma-informed way to the patients that walk through the door. Hopefully, we're doing staff trainings that we have these conversations about them, and that we as an organization are going to provide a safe environment, and that we're going to really approach it like a universal precaution, right? We don't know if somebody that we see that has a cough and a fever has COVID or not, but our clinical staff is covered up and they have PPE on just to make sure. It's a universal precaution, right? So we're going to do this also with individuals that may be coming through our door because we don't know if they have had a presence of trauma in their life, and we're going to want to serve them in the best way we can, as if all of us have had something in our background that we need to sort of pause and take concern about. So sometimes our centers, as I said at the beginning, are very trauma informed, and some of us might work in centers that are not as trauma informed. So what can we as individuals, what can you do as you're approaching your patients? We need to resist re-traumatization. And sometimes the environments in some of our clinics are pretty toxic. They interfere or they re-trigger some memories about an experience of discrimination, of not being wanted, of even of violence that is verbal violence in terms of how staff might talk to each other, that we really need to bring it down, so to speak, bring that temp down and think, how are we treating each other? What is the environment for the staff where we work so that we are being not triggers, but rather a safe environment for everybody? And some of those triggers might not be something that we can point to very easily. The person may not remember everything, but they remember that there's something about this interaction that seems hostile to me, and that makes me react in a very emotionally negative way. And so trying to change our policies and procedures about how we talk to each other as a staff and how we talk to the patients that walk in through our doors becomes very important. So trauma-informed care is basically not only are those four things of recognizing and trying to not re-traumatize folks, but really they're based on these core principles. And there's 6 core principles that we take a look at in terms of making it a safe environment for our patients. So folks have to feel like they're physically and psychologically safe where they are. The physical surroundings have to be safe. They have to feel like when they walk in, there might be posters or languages or people there to interpret that make them feel safe, that make them feel like they're wanted in this environment, and that their interpersonal interactions are one that promotes safety, but not a hypervigilance of, gee, this isn't a very friendly environment. I need to get out of here because I'm not sure if they're going to respond to my needs or what. So safety becomes one of those principles. Being trustworthy and transparent so that we build and maintain trust with the patients, families, and among staff. And I can tell you that this is particularly important in rural communities where individual providers and staff may often be part of the community. I know that some years ago, a few years ago, we had one of my medical students did a study in our women's health unit, and we wanted to see if they were really systematically asking about domestic violence situation for our women patients in the women's health department. And it's very interesting because, as we would expect, the numbers were high of women that had either had the experience of violence in their life or were currently in a situation of violence. But their willingness to talk about it had a lot to do with who asked them about it. And a lot of times, the nurses and where they were situated that asked them did not really trigger the responses that were as accurate. And a lot of it had to do with them being people that were part of the community and the patients not feeling safe, that this was going to be a safe information that was going to stay in the clinic. So even, in the rural communities, it's important for us to consider that our staff is part of the community and how we can relate to patients and be very explicit about it, that what you tell us, what you talk about here in the clinic is private. It's not something that someone is going to talk about at church on Sunday, for example. Peer support. Those of you that are promotoras or work with promotoras, you know how important this is. Establishing safety and hope, talking to someone that may have had the same community experience, that is part of the community, that understands your experience in life because they've been through it. That really enhances collaboration. It utilizes stories of the promotora, their lived experience of peers. That becomes very, very important. And we can call them outreach worker or promotoras, or other clinics have had other types of peer supports, example for teenagers, elaborating on enhancing teenagers' experience by having other teenagers in the local high school that may have had issues, for example, with mental health, and making it be okay that we can talk about mental health issues. So peer support becomes one of the key principles when we're trying to take a trauma-informed approach. Healing happens in relationships, right? So it's the relationship that I have with someone else, that importance of partnering and joint decision making. Not that I want someone to tell me what to do, but that jointly we make a decision. And sometimes this is a little by little steps. Often we work with folks that are used to seeing the providers as the authority figures, and what the provider says is what I'm supposed to do. And so they will nod and say, yes, sir, yes, ma'am, or yes, doctor, this is what I'm going to do, because they don't question it. And I don't know in your clinics, but what happens in our clinic a lot of times is that the physician will say something to the patient about what they're supposed to do. And the patient won't question it. They'll just say yes. And then as they're walking down the hall, they'll grab one of the psychologists and say, what does it say that I'm supposed to do? Because they're afraid to ask, even though I would consider our physicians to be quite friendly and they're bilingual, but it's that authoritarian, I'm supposed to say yes to an authority figure. So teaching little by little, particularly those patients that we follow through over the years in primary care, that this is a joint partnership, and we need to involve patients. We know patients know what's best for them, and we need to bring them on with this principle of collaboration. And also the importance of that partnering within the organization itself. Everybody makes a difference. Housekeeping, the executives, the professional staff, they all have to be helped to understand trauma-informed care. That the relationships we make with people, oftentimes, the nursing staff hears from housekeeping when somebody comes in, hey, I know this person is having a hard time. They just said something to me. Maybe you need to talk to them. So while not giving up any individual information, seeing it as a team, and that collaboration becomes really important from the time of front desk check-in through nurses, through physicians, the psychologist that might talk, or clinical social worker that might talk to the patient, all the way to checkout, that this integrated care principle, one of collaboration, is something that goes a long way towards trauma-informed care. And then empowerment and voice and choice. So that organization that really fosters the importance of the people that we serve, um, the resilience and ability to promote healing and recovery. We just assume that our folks have been through a lot of trauma, a lot of adversity, and supporting the patient in terms of what is their choice, what they think. A lot of times, from our point of view, we may see a family coming in and we see so many needs that this family might have, that we immediately start thinking, well, you need a referral to this and a referral to that, and you need social services, and you need this, that, and the other. And the family may not really be ready or want all of that. They're just happy to be here and to be alive. They've been through hell and back, but they're together now. And that empowering them to know that they're very resilient, and that we think they're resilient, and that we respect what their choices are of what they think that they might need at this point in time. We don't have to resolve everything today. We have to resolve the relationship and the family and the child feeling safe here. And then we can move from there the next time around when they come in. And then, of course, the principle also of cultural, historical, and gender issues. And organizations have to move past the cultural biases and stereotypes. And becomes really, really important, because when someone walks through the door, people that work, whether it's the physician or the frontline worker, we all have our own implicit biases that we have as we talk to someone, and we may make judgments about who they are based on our own history. And so being able to go through trainings on bias, on historical trauma, on differences among people, and being able to know who our community are, and to recognize that there might be biases in the community, and the biases go both ways. Sometimes I give the example of when I was growing up in Miami, and this was back in the 60s, it's not the Miami of today, those of you that know Miami. We did leave our doors open at night, and people are appalled by that, but we were a smaller community, not the community that Miami is today. But as an immigrant in a Cuban family, my mother was very conscious of raising us in the Cuban way, whatever way that was. But it certainly had a lot to do with protecting their teen daughters, right? And so there were a lot of things that we were not allowed to do, because that was something las Americanas did. In other words, the American girls did that. The Cuban girls didn't do that, according to the biases that my own family had. And so, when you heard it from their point of view, you would think that these quote unquote American girls were going out and having sex every night in the back of somebody's truck or car, when all these girls were doing was just going to a school dance. But people that come in, it's not just the majority culture that has their biases. The minority culture also has their biases. And so what we hope to be able together as an organization to come together and talk about the biases on both sides of the aisle, if you will. After many years, and I raised my own children in Tallahassee in northern Florida, which is very different than Miami. And my mother would come now many years later to visit me, and bless her heart, as the Southerners say, she had evolved a lot. She had acculturated a lot. And so when my then, for example, 17-year-old daughter was going out on a date on a Saturday night to have pizza and a movie with a male, and then would come back, she didn't have that trigger of, oh my God, she's going out alone and they're going to have sex in the truck in the backyard. What she had come to realize is that it's okay. They can go out to a movie. I know this young man. They can go and have pizza. They're going to be home at a certain time, and that's okay. And so I bring out this example just because we often think of discrimination, of the majority culture discriminating, but we all have our own biases. We all have our own ideas about other cultures and what they do and what they don't do. And it behooves all of us to grow as an organization and as individual providers to learn what our own biases are that may be impacting our patient care. So within primary care, we really want as a goal to identify children who have experienced traumatic events with a particular focus on the physical, mental, and behavioral health needs. And so screening for traumatic stress should become something that's part of routine well child visits. And then identifying strengths that help the child and the family cope. So reinforcing the resiliency that may be a part of that family. So we're screening, we are assessing, because sometimes we screen and somebody says they were divorced, the family, there was a divorce. But when we think about that and we talk about them a little bit more, it happened 3 years ago, everybody's getting along fine, the child is able to see mom, able to see dad, they've moved on. That's not traumatic. It was a stressful event at the time, but that's not a trauma. It's not impacting functioning, and it's not there gnawing at the family. So we want to identify in that particular situation that there are some really good coping strategies that this family has, and that the parents have been able to share this child and to educate this child and raise this child together. And we want to reinforce them for having done that. So when we look at our children, what are some of those toxic stress signs? What are some of those signs that we look for? Well, problems in school, like every other thing that might impact a child, because so much of the child's life is spent in school. Children becoming easily irritated, being distracted, being hyperactive or impulsive, having difficulty relaxing, concentrating. The other extreme of being very withdrawn, dazed, kind of forgetful, shutting down emotionally. It's hard to reach this child. And then often what brings them into the primary care setting is because they're having headaches or they're having tummy aches, and we don't understand why it is that they're having tummy aches. So Jenny, the case I read at the beginning, was having difficulty with those headaches and I'm sorry, with the tummy aches, which she wasn't quite sure, but she knew she didn't want to go back to school because whatever it was in her mind had happened, it had happened in school. And actually, a little bit more towards that case, one of the things that had also happened to Jenny is that somebody said to her that a neighbor had been found to be illegal and had been sent back to their country of origin, and that might happen to her too. And so while that was not necessarily an issue with Jenny herself, needing to talk about that became something important, and we'll talk about that in a minute. So we want to encourage resiliency. It's like a half full if we don't. If we only talk about adversity and we don't talk about resilience, we're not doing our good to our families. And so when we talk about that, we talk about children that can go through a lot of adversity and come out the other end pretty well, is having confidence ensuing in them, not always telling the kid that they don't know what they're talking about, but good for you for trying, and good for you for, I'm glad, and I want you to take initiative, and I want you to solve this problem. So instilling confidence in the child, instilling competence. It's not okay to just say that they're always doing something right if the kid isn't saying it right, but rather than saying, you don't know how to do anything, why do you do everything wrong? Helping parents to say, let me help you learn how to do that. that's not quite where you want it to be, let me help you learn how to tie that shoe or how to cook that. The connections with other people, it become very important for children. Connections, not just in the family, but outside of the family. Character, knowing what's right and wrong. There are some things that are right and some things that are wrong. And children need to learn that early on as they grow and their ability to see gray becomes better during their teenage years. They can start to think about things in the context of gray. And while in some situations something that was normally wrong might be okay, but as children, they need to have a sense of, yes, this is wrong, and yes, this is right. And this is what my decision making is based on that. So that character building, their contribution, that they can contribute to the family, they can contribute to their church, they can contribute to society in some way, that they're not just the recipients of. A few years ago in North Florida and in Quincy, we had a lot of tomato fields, and we would run clinics in the summer for the migrant school. And kids that were in migrant school are our nurse practitioners and our medical students would do the physical exams so that they could be ready for school in the next place that they were going. And one year, the woman in charge of migrant ed decided that what she would do is that she would give each of these children who came from migrant farm working families and whose parents were working either preparing or harvesting the fields and tomatoes, a parent donated, they brought in a big basket, and each child, as they went in for their physical, they had a tomato in their hand, and they offered it to the provider as a thank you. And of course the provider was thrilled, and they were so glad to receive this and thank them. And this was a way of teaching that yes, we receive, but we can give a lot. Also, we can give to others, and that contribution to society allows a child to see their place and how they're contributing to their community. Coping, giving children ways of dealing with stress. It doesn't help to protect them from stress because they're going to encounter, as we all know, we all encounter stress. So having them learn some basic coping strategies and finally feeling like they have some control about what happens. So what can we do? What can you do? There are some factors that predispose children to positive outcome in the face of adversity. And those are those factors that we just talked about in terms of resiliency. So you can support facilitating supportive adult-child relationships. That is always something that is important for a child, with a coach, with a teacher, with an aunt. Building a sense of self-efficacy and their perceived control that, yes, I can do this. I can, there's not everything in the world that I can control. There's some things I can't control, but there are some things like how I deal with stress in my own body, how I can do relaxation, how I can breathe, how I can ask questions that I do have some control over. And so providing the children and families opportunity to strengthen their adaptive skills and their self-regulatory capacities that we can teach them. Mobilizing sources of faith, of hope, of cultural traditions. We know, and the research shows us, that a sense of hope is really, really important. Hope is what keeps folks walking all those distances from Central America all the way to the border. There is this hope that when we get there, things are going to be better. This is really hard. This is a hard walk. We have all this adversity, but when we get there, it's going to be better. That sense of hope right now in this year, by the way, is what we're seeing in our patients to have been pretty devastating, because once you go through this adversity of trying to leave your home and immigration and going to the other side, you have this hope that things are going to get better. But when you get there and things totally fall apart, that hope is gone. It is so much harder to help our patients to continue on, because that hope that they had, particularly with the children that are in that no man's land, right? Where maybe the parents have gone back and they don't know what's going to happen or when they're going to see their parent again. That sense of hope that nobody can say, hey, 6 months or 2 months, or they just don't know. So that becomes really difficult. But holding on to cultural traditions that have a sense of continuity for the child and the parent becomes really important. Teaching positive parent-child interactions, very important. It's not something that you're totally born with as a parent, to know how to interact positively with your child. Sometimes we need to teach some of those positive skills. And then addressing maternal mental health. We know that the moms have a big say in terms of raising the children. And to the degree that we can address mom's own depression, mom's own anxiety, her own experience of maltreatment, that is going to help. So I always tell my medical students that want to go into pediatrics, you don't ever have one patient when you're in pediatrics, right? You have a minimum of two, possibly three, and possibly more. So the child is raised with parents. They're in a home that has other people. And to the degree that we can assess how well those parents are doing, we can really help in terms of those protective factors for the child. So stepping back to Jenny, that we talked about at the beginning of this talk, what can we do for Jenny? Well, we can educate about the relationship between anxiety and somatic symptoms. Not everybody knows that when you're really nervous about something, your tummy hurts. And so allowing for some teaching, some psychoeducation of Jenny and her mom about the link between these two things. Teaching relaxation techniques that can be very easy to teach, that there are apps for that you can have them download on mom's phone that can help them through breathing techniques. Educating mom about the relationship between depression and parenting. You know, we have like a handout, and you can go to our website and get it, on depression, and helping moms, even if they're not in a clinically depressed range when we screen, but educating moms about that link between mom's mental health and her depression and how it may impact her parenting and her child's well-being. So psychoeducation about that, and encouraging mother's self-care, that, you know, being a sacrificial lamb is not going to be very helpful for your children, believe it or not. Taking care of yourself. And so mom self-care, we've got a campaign about that you can get for free if you go to our website, and you can help with your moms. Teaching mother how to talk to Jenny about deportation and how to prepare the family in case she is in a situation where someone in the family might be deported. A lot of our parents don't know how to talk to the kids about that. They don't have the words. And so we have a series that we do with the parents about teaching them, you know, how to prepare the child in case that were to happen. Around here at South Florida, so we all prepare for hurricanes. We don't always have a hurricane, but we can at least prepare for the hurricane and just say, hey, great, it didn't happen this year. And we just put all our flashlights and water away. Encouraging school attendance. The fact that she's staying away from school, that's a problem. So we need to encourage her going back to school as quickly as possible so that that's not become a pattern for her. And then encouraging another adult in her life. If her own family and her own mom is pretty overwhelmed right now, encouraging mom to have her involved with sports, a coach or a trusted family friend that they can go out and do crafts together, or a teacher that she can become close to. So, you know, it does take a village to raise a child, and encouraging parents that, you know, to take advantage of a community that might help them, and nurturing their child through these stressful times is really important. So we said we would stop and have an opportunity for those that want to stay on or that want to put in the chat some questions that maybe I can address, or some comments.
I don't see any questions that have come in so far in the Q&A feature or in the chat box. So if you all have any questions, feel free to enter those either through the Q&A feature on the bottom of your control panel or in the chat box.
And I've also put on our website. Anybody can go to our website and I would, like I said, we have a media campaign for moms of posters and things messaging that you can do with your moms for self-care. Those are all free. Just go to our website, fsustress.org, and you can download them. We have them in English, Spanish, and Haitian Creole.
We did have a question come in, Dr. Reyes, of whether or not the resources are in Spanish or in other languages.
Everything we do is in Spanish and in Haitian Creole because our community has English, Spanish speakers, and the Haitian Creole speaking population. We make a point that all of our materials also are at a low literacy level so that they're understood by our folks. So you're free to download anything, or if there's anything in there that we actually have paper copies or posters or things like that, we'll be happy to send them to you. But yes, our media campaigns are all in Spanish and in English. And we have an ebook after the harvest that parents can go to the website, or providers can go to the website. And it's about, little bees, and it's really about migrant lifestyle, right? Where you go and as a kid, you start getting tummy aches because you're going to school and you don't know people, or once you've made friends and then you have to leave your community. And so it teaches relaxation. It teaches the connection between body and mind, and how sometimes when we're worried, that allows for our body to respond, and usually with pain. And what are some things that they can do through breathing exercise, imagery, that sort of thing. And it is an ebook, so it's free. You can download it, or you can just go on it and walk the child through as many times as you want to.
Thank you. I was curious, in light of COVID now, Dr. Reyes, would you consider COVID as an adverse event? And if so, have you seen a significant impact amongst agricultural worker families or the families that you serve within the Child and Stress Center?
Absolutely, yes. Kind of like Shakespeare, and how there's so many ways, right? So, for our families that don't have the option of staying home and teaching their children, or if they do, they have all sorts of barriers. So our school systems have given iPads and have given, computers and this sort of thing. But our parents are very stressed that they may not know how to use the computers. They don't know how to help their children. They don't know the language. They feel inadequate. They feel that they're not doing right by their child by not being able to provide them with the help that they need. It's also been very difficult for them in terms of isolation. And, when we were at that point where people were not supposed to, be hanging out with other people, but had to have masks on and this sort of thing. So we actually started a campaign. Again, you can go to our website and download anything you want for free. It was last summer when we did the, having to use masks and ways that could relate. Our Department of Health had their materials translated to Spanish, but it wasn't really resonating culturally with the community, and so we developed our own campaign, which seemed to do better. And there's actually a coloring book that you can download also, and it has to do with it's an activity book with dealing with the stressors of corona and explaining to children what COVID is and that sort of thing. But we have seen in our community that for the migrants, it was very difficult because they didn't have the space. The children were not getting the help. Of course, there was the whole issue of getting food, which most of them got a lot of their food from breakfast and lunch at schools. And so they were distributing that through the bus stops. But the stressors were definitely there for the parents in feeling inadequate, that they could not provide what the child needed, particularly in the homeschool situation, because either they didn't know English or they had to be out in the field and they could not be monitoring the children. So we know that a lot of our children this year fell way behind. academically where they needed to be because of having to miss the school.
And I think that was also something experienced by many other children, not just those of our agricultural workers across the country. But in particular with this population, you mentioned earlier a big impact on social skills. Now with the transition to this virtual world and even providing school via the internet, how have you seen the impact of that on children socially and their ability to create these relationships that could help them cope and move forward with stress?
One of the dangers that we're seeing in primary care, it's interesting because I was just talking to a colleague about this, is that since the children know a whole lot more about how to access things on the internet than their parents do, that they're getting into some really difficult situations of chat rooms and talking to people all over the world in different clubs and not recognizing that they might be talking to an adult and not just somebody that has something in common in terms of a hobby with them. And the parents are so overwhelmed by it, because they don't understand it, they don't know what this means, and they don't understand how to deal with it. So we had one mom yesterday in the clinic that basically what she's doing is unplugging their internet, because she just doesn't understand any of it, and she doesn't know why it is that her 12-year-old is spending till 1:30 in the morning talking to somebody around the world around some anime characters. And so they're trying to find a world that they don't understand in order to protect their children. And so there's a lot of psychoeducation that I think is needed in the primary care settings for parents around the internet and children not having the usual access that they after school and the soccer team, all these sorts of things that children may have been involved with this year and have turned to the internet for a lot of that social support, and unfortunately can be getting themselves into trouble for it. So we really are recommending that parents really think about starting that socialization process again for the children, whether it be in their church groups or allowing them little by little to go outside and play with a couple of kids from the neighborhood, because the children are becoming more isolative and turning to the internet for that socialization that they need.
Yes, and I can definitely see the benefit of maybe educating parents so that they have a little bit more guidance on some of those safety measures online. So now to address a little bit of the concern with vaccination, because I know that you're probably aware that CDC recently approved the Pfizer vaccine for children 12 and older. So considering your experience as a physician, working with children, how would you address maybe some of the stress that parents might vocalize about getting the COVID vaccine or any hesitation they may have in getting the vaccine for their children?
So one, I want to clarify, I'm a psychologist, I'm not a physician, although we work in integrated care side by side with our colleagues of physicians. This is such a new thing that the only thing that we have to draw on now is we've done some studies on HPV vaccine uptake. And, a few years ago, all of the mainstream journals were talking about hesitancy of parents to vaccinate, particularly their young girls, with the HPV vaccine. And we did a local study with the migrants and really followed up. We had an NIH money to do it. And what we found, interestingly, was that what everyone was talking about in terms of the mainstream journals was not what we were finding among our migrant families. That the idea of vaccines was accepted if they understood, if they were given information. And as we looked at different variables, the number one predictor of whether a mother assented and consented to her child being vaccinated was if the physician recommended it. And so that's what, going back to this presentation, the context of relationships and the importance in a true trauma-informed environment to have a relationship, for that physician to take the time and explain to the parent, why it is, why this is important, why your child should be vaccinated or not, depending on the health status of the child. I don't have, because we don't have enough data yet coming out from this particular situation, but we have found that our families, if we take the time, not as a necessarily just in general, get in line, but the physician that knows you, that knows your family, explains to you why this is important, that we did not have the numbers that at the national level folks were complaining about, that the girls were not receiving this HPV vaccination. As a matter of fact, it was very interesting because one of the reasons nationally was that they were thinking, well, this is sort of giving permission, and in majority culture, some of the research that was coming out was this is sort of giving permission for the girls to go out and maybe have premature sex or whatever by giving this. I mean, it was really kind of crazy. But for our families, they weren't thinking like that at all. They had a history of accepting vaccines. And if the doctors explained why this vaccine was important, they would take it. And so that's extrapolation, because we haven't done it with this vaccine now. So it's extrapolation of what we found in the past. But I would be willing to say that if we had people that were there that were willing to answer questions, this is a great place, I think, as an outreach worker or promotoras to have. If you have a place where parents, even if they're standing in line, can have people that are explaining to them why this is important, or at health fairs, somebody from the community that's an authority figure, I think that it would be very helpful. But again, that's extrapolating from data from our previous vaccine situation.
Thank you for that insight, Dr. Reyes, and for clarifying your role within integrated behavioral health. I do think there is a strong connection within primary care and mental health, and now that we are seeing more programs of integrated care, the two are obviously very interconnected, and there's a lot of potential for collaboration to be able to educate and inform the families that come in for services. So to wrap up today, and I don't see any other questions coming through, but I do have one more for you, just in speaking about the importance of our workforce and of collaborative relationships amongst each other. You mentioned earlier that burnout can happen, or that staff can become triggered themselves by something shared by a patient. So recommendations that you might have for the workforce today, considering the impact of COVID and truly their own mental health, any feedback or comments that you have in terms of how they can maybe address some of those concerns for provider burnout or compassion fatigue in light of the environment that they are working in today?
Yeah, I really would encourage a lot of lobbying towards the clinic administration to have something. And it doesn't necessarily need to be a support group where everybody gets together to talk about COVID, but a place where they can share, and like a lunch, a once every 2 weeks or once a month lunch where anybody can come, bring your lunch, and we can just share as a community. And at the end of that lunch, we're going to have a little 10-minute exercise on meditation or relaxation. We have found that to be really beneficial, that people have really liked it. And it just is almost like a reminding of folks that, yes, we're all in this as a group facing this adversity, but there is something individually that we can do. And even though we go, oh, well, breathing isn't going to do anything, well, let's do this together, and let's take some cleansing breaths. Let's do some relaxation together. Let's kind of get re-energized, kind of like putting gasoline in the car, so that we can go out there for another 2 2 weeks. So I encourage this. I encourage it in the clinic. I would encourage you to, even if it's not for everybody, but whoever wants to come. I mean, not a required thing, but whoever wants to come, make it a place where people can go and just have lunch together, but knowing that at the end, they will have this experience together. We have found that to be helpful. And it's not a requirement. This is what we have. And the other thing about that is that it doesn't separate staff into, professionals and frontline staff, but whoever wants to come, it's okay to be able to do this. And I have found I obviously have this hat as administrator here, not in the clinic, but administrator for FSU. And I have found that, we really as administrators need to be able to step back and say, everyone is burning out, everybody's super stressed out. And so allowing for people, to make it okay that sometimes somebody is going to have to miss work, that sometimes, just even when my child is not going to school today, the babysitter at the last minute couldn't come, I have to stay home. Rather than just saying, okay, well, I guess I'll see you tomorrow, to take a minute and talk to them and just reflect back on how stressful that might be, because nobody wants to call in late or call in absent from work because they're stressed out because of their kid. So just an acknowledgement from administrator that must be really hard to be in this situation, and I'm sorry you're having to go through this. That I have found that is very helpful, because it's like we all share this commonality in this workforce of having to acknowledge the adversity that's surrounding us. Work is not separate from life, it's all together. And so acknowledging that this is distressful and that I'm sorry that this is happening, I have found that has been helpful. People have told me that has been helpful. They have felt supported, rather than, oh gosh, what am I going to do? One more employee isn't here today.
Thank you. I think it is important for management, administration to be mindful of what is currently happening with the mental health of their workforce, and to make plans accordingly to provide support, whether it be allowing for time for PTO, incorporating some lunch and learns like you mentioned. So that would be very helpful. Even having wellness programs, I think incorporating that into the workforce as a usual type of environment would be very beneficial.
Yeah, that anybody can access, making that information, in bulletin boards around the clinic and places, in the lunchrooms, wherever that people go, of, yeah, this is a part of life. And you had mentioned something before about primary care and specialty care in terms of mental health. I don't know what your audience is seeing, but it has totally blurred for us. The community mental health center, everybody went home, with COVID, and they were doing mental health through mental health services. And our patients, just some of them could do that, but not a lot of them. They just did not relate to it. And a lot of them had a difficult time accessing, because of their computer, of how to go through telepsych. And so we are seeing in primary care a full-blown, usually we do health psychology, right? Chronic disease management and that sort of thing. We're seeing as if it was a mental health clinic, because the stress is so big out there that people are coming in and they're wanting to see someone here in primary care. So we're having to address it whether we want it or not. It's coming into primary care.
Right. Well, thank you, Dr. Reyes, for a very informative presentation this afternoon. I don't see any additional questions in our chat. Some comments that went through and questions from me during the presentation to elicit audience feedback, but we thank you for today's presentation and for the great information and resources. I did enter the ones you pointed out into the chat from FSU, so those are available to our attendees. Sylvia Gomez will also be providing those links additionally in our follow-up email, so we encourage everyone to be on the lookout for that, as well as a copy of today's presentation. We encourage participants to also complete the evaluation that Sylvia will be sharing, but we do thank you, Dr. Reyes, for your time and for your expertise in coming to present today.
Absolutely. Thank you for having me.